Hello, welcome everybody to the third in our series of Journal Club presentations for Facebook Neurology for Veterinarians. Good morning, good afternoon, good evening, wherever you're tuning in from. Thanks very much for giving up the time to do this. Thanks to Hallmark for sponsoring these Journal Clubs. And if you've not attended one before, the previous ones are online for you to access. And this one will be recorded too. We have people come to present their latest work that's been published and tell us why they did the study, how they did the study, and what the results are. And today we have great pleasure in introducing to you Dr. Sarah Silva. Thanks very much, Sarah, for coming and being part of this. It's great to have you. To read out for everybody that Sarah's bio. She qualified from the Faculty of Veterinary Medicine at the University of Lisbon in 2016. And then following that, she undertook a surgical internship at Fitzpatrick Referrals. Then she did a year in general practice in Warwickshire and moved to Scotland to do a one-year rotating internship at the Small Animal Hospital, University of Glasgow. So hello to our friends there. After this, she completed a neurology internship at Queen's Veterinary School Hospital. Hello to our friends there. And then joined the team where she currently is as a resident at Langford Vets, University of Bristol. Hello to our friends there. I hope they're all tuning in, Sarah. No doubt they are in support of this. And so you're here today to tell us about your study, which we're pretty excited about, is clinical signs, MRI, and long-term outcome of foraminal and far lateral disc herniation in dogs. So great topic. Without further ado, we're going to hand over to you to get us started.
Thank you very much. Hi, Simon. Hi, Lohan. Thank you very much for having me and for the introduction. As you said very well, I'll be presenting the findings of a project that I worked on with the neurology team at the University of Glasgow whilst I was a rotating intern there, although now I'm a neurology resident at Langford Vets. And it's on clinical signs, MRI findings, and long-term outcomes of foraminal and far lateral thoracolumbar intervertebral disc herniations in dogs, so quite a mouthful. And so as an introduction, well, some of you might be very excited about the idea of another study on intervertebral disc disease. Others might be wondering why did we decide to do one or another one. And although we all know intervertebral disc disease is a very common neurological disorder, our studies sort of different slightly in the sense that we'll be talking at a less common location. Most intervertebral disc extrusions, as we know, are reported in the thoracolumbar junction, which is somewhat contrary to those in our study, which we'll be seeing later in the presentation. We'll also be discussing a slightly uncommon type of intervertebral disc herniation. When we look at the picture on the left here, we know that more often extrusions will either be central or slightly lateralized within the vertebral canal. And this is obviously believed to be due to intervertebral disc morphology, in which the dorsal portion of the annulus is thinner than the ventral portion, whereas in our cases, disc herniations will have more of this presentation and characteristics, in which the compression will be sort of external to the vertebral canal and either at the level of the foramen here and or external to it, which we've called far lateral. We also think that there's and saw that there was limited literature on the topic. We know that the clinical signs, MRI characteristics, and outcome after medical treatment of intervertebral foraminal disc extrusions has been previously reported in the cervical region in the study by Burson and colleagues. However, to our knowledge, there's only been two case reports in the past previously describing far lateral extrusions in the thoracolumbar vertebral column of dogs. And those were treated surgically, one by Angela Fada and Frank Forterre in 2013, and one sort of slightly older study from Bagley and colleagues in 1994. And so the reasoning for us to do this study and the reasons behind them were sort of mainly the fact that we'd seen some of these sort of slightly challenging cases that presented with either lameness and or hip or back pain, which couldn't quite understand initially whether they were orthopedic or neurological. And obviously this, coupled with the study by Burson and colleagues that I've just referred to about foraminal disc herniations in the cervical region, made us want to sort of collate some cases so that we can sort of better understand the clinical presentation of this disease. And so our aims were therefore to retrospectively evaluate the clinical signs, as well as describe the MRI findings, as well as long-term outcomes after medical or surgical treatment of dogs diagnosed with thoracolumbar intervertebral foraminal and lateral disc extrusions. And so obviously in terms of significance, to our knowledge at least, this is the first case series describing this sort of uncommon presentation of what we know is a common condition. And so in terms of methodology, we retrospectively searched the medical records of 7 referral institutions between July 2009 and October 2020 for dogs diagnosed with thoracolumbar intervertebral foraminal and or lateral disc extrusions between T3 and L6. In terms of inclusion criteria, we wanted complete medical records, clinical signs and neurological exam findings compatible with our diagnosis, and also MRI confirmation. And then in terms of inclusion criteria, still we defined foraminal or lateral thoracolumbar intervertebral disc extrusions as presence of intervertebral disc material within, which we've called foraminal, which we can see here in the image on the left, and or outside of the limits of the foramen, which we can see here in the image on the right, which we've called lateral, again in the thoracolumbar region, and so between the 3rd thoracic and the 6th lumbar vertebra. In terms of exclusion criteria, we decided to exclude L7S1 intervertebral disc herniations because foraminal stenosis secondary to lumbosacral disease is quite frequent and we believe might represent an entirely different pathological process. And another exclusion criterion was the presence of herniated disc material within the vertebral canal causing spinal cord or filum terminale compression. In terms of diagnostic imaging, the MRIs were reviewed by 2 authors, so myself and Rodrigo, and then we looked at the site and lateralization of the lesion, the degree of intervertebral disc degeneration determined by the Fuhrman grading system, the presence of nerve root or spinal nerve enlargement, nerve root or spinal nerve or perilesional contrast enhancement, and any changes to the epaxial musculature that we could see. And in terms of classification, we classified an herniation as intervertebral foraminal when the extruded disc material was confined to the neuroforamen, and so between the medial and lateral borders of the pedicle, which again we can see here in the image on the left, and then far lateral when the disc material was considered to be outside of the neuroforamen, so outside the lateral border of the pedicle. And in some cases, we when the material was confined or localized to both the foraminal and a far lateral location, we defined it as both when it extended over both regions. In terms of outcome, we considered it excellent when there was complete resolution of clinical signs, good when all pre-treatment clinical signs were resolved, but the dog still had occasional mild signs of pain or pelvic limb weakness or lameness, and then poor if the patient failed to improve, suffered deterioration, or experienced a recurrence within the short-term follow-up period. And so when it comes to our results, we included 37 dogs. Also, one of the dogs presented on 2 different occasions with 2 different, two disc herniations at different sites, and so we included that one twice. In terms of breeds, the most affected ones were Dachshunds and mixed breeds, and both representing 22%, and then other breeds were common ones like Cocker Spaniel, Beagles, and Shih Tzus, for example. The median age of presentation was 6 years, and weight was 11 kilos, as is common for disc extrusions. The median duration of clinical signs was 14 days, but it was quite a wide range, up to 660 days. And in terms of clinical signs, lameness was seen in 71% of cases, so most of them. In 92% of cases, there was pain, and this was either on lumbar palpation, hip extension, lumbosacral palpation, and in some cases, thoracolumbar or even tail manipulation. The postural reactions were normal in most cases, in 53% of cases. Pedal withdrawal reflexes were abnormal in only 34%. And the patellar reflex was only abnormal in 26%. and unilateral pelvic limb paresis was seen in 21% of cases. So here we can see a little video of one of our patients. Hopefully you'll be able to see it without too much lag or delay. And we can see here very clearly this right pelvic limb lameness in one of our cases. She's obviously quite reluctant to stand here and to some extent to walk as well. This one had L5, L6 disc herniation, so in testing postural reactions, there's no obvious deficits that we can see, but she is clearly offloading that limb when being tested. There's maybe some pain on hip manipulation here, not quite clear. No obvious craniothoracic or thoracolumbar pain on palpation, but here perhaps some pain on lumbar palpation. It will be a bit more obvious later on. Very comfortable for tail manipulation, and then slightly reactive here on lumbar palpation with some lip smacking. There's much more obvious here is pain on hip extension on the right, which we can see here. She immediately lies down. Then again, testing for hip pain, no obvious positive ortolani sign here. And then very clearly she is very uncomfortable on extension of that hip, but very comfortable on the contralateral one. And then for reflex flexing here, patella is normal on the contralateral limb. And then although not tested on the dependent limb, it seems to be absent here. And then a little sneak peek at after the surgery, in which her lameness seems to have much improved, which was a nice case for us to show. Here we are. So when it comes to our MRI findings, as I said, a total of 38 foraminal and/or far lateral disc herniations were documented. As I said, this was because one patient presented with herniations at 2 sites in 2 different occasions, and they were at the level of L5, L6 in 50% of cases, and then in 37% they were at L6, L7, but then in some cases it was at 12, 13, L1, L2, L4, L5 as well. In 42% of cases, they were considered both far lateral and foraminal, and in 34%, they were considered to be just far lateral, and in 24%, just foraminal in their location. When it comes to the degree of intervertebral disc degeneration of the affected sites, which was assessed with the use of the Fuhrman grading system, as I'd said, it was considered to be 4 in 84%, so most cases, and then in the remaining ones it was 3, which is unsurprising that most of these discs had marked signs of degeneration. In terms of nerve root enlargement, this was seen in 89% of cases as well. In 19 cases, contrast was administered, and in all but one case, so 95%, contrast enhancement was seen. And this was both nerve root and paralesional contrast enhancement in 63% of cases, and paralesional contrast enhancement alone in 16, and nerve root enhancement alone in 16 as well. And we can see here quite clearly images, T1 transverse images pre and post contrast in one of our cases, in which we can see very clearly, oops, sorry about that. We can see here very clearly the both sort of paralesional and nerve root contrast enhancements in some cases. We also obtained stir sequences in 23 cases, and then in 57% of these, there was this hyperintensity of the epaxial musculature seen, which we can see here in a dog in one of our cases, in which we can see this sort of right-sided hyperintensity, very clear, of the epaxial musculature, which is quite clearly adjacent to the herniated disc material here, and this is obviously at L5, L6. We also performed or had radiographs available in 12 cases, and in 11 of these, there was evidence of calcification in the region of the herniated intervertebral disc. and then 6 of them had this mineral opacification at the level of the intervertebral foramen, which we can see here in the image on the left. And then in 5 of these, there was presence of mineralized material that was lateral to and or at the level of the foramen, which we can see here also in the image on the right. And in two cases, there was also some evidence of narrowing of the intervertebral disc space that was affected. And these were interesting images and interesting cases that make us think and highlight that radiography might be of some value in these cases. We also did CT in 2, and this was available in 2 cases, and in both of them there was evidence of far lateral and or intervertebral foramen calcified disc material at the affected site. And so we have here a CT transverse image at the level of L6, L7 here, which very obviously shows this sort of blob of calcified disc material in and outside of the right foramen of this patient. And so when we look at treatment, in 38% of cases, they were treated conservatively alone, and all of these had gabapentin as medications. Of these, 53% had a non-steroidal, and in 33% of cases, they had prednisolone instead. In 61% of cases, had surgery, and this was in all cases that either failed to respond to conservative treatment or had a recurrence of clinical signs following medical treatment. And so in 52% of them, so most of them had hemilaminectomies, and in some of these it was combined with sort of fenestrations, corpectomies, and foraminotomies as well. In 26% of cases, spinal nerve decompression without bone drilling was performed, and in 22% of cases, a foraminotomy was performed. And so when it comes to outcome, our median follow-up time was 36 months, but again, the range was wide between 3 and 108 months. The overall outcome for all patients was 77%, was excellent in 77%, and then good in 16%. And then when we look at the surgically treated patients, 86% had an excellent outcome and 10% had a good one. And in terms of medically treated animals, 70% had an excellent outcome and 20% had a good outcome. And so in terms of sort of topics for discussion, as I said, in most cases, a combination of 2 or more surgical procedures was performed, and this was obviously not only due to surgeon preference, but also because of the characteristics of these intervertebral disc herniations. And as we can see here on the image on the left, in cases in which sort of foraminal involvement was observed, then osteotomy procedures such as hemilaminectomies, foraminotomies, or corpectomies were required for decompression, whereas in some cases in which the extruded disc material was in more of a far lateral location, then it's easy to understand how spinal nerve decompression alone without the need for bone drilling can be deemed more appropriate. We can also see here a T2 weighted sagittal image of one of our cases with a far lateral disc herniation here at L5, L6, in which, as expected, there's no obvious evidence of disc material within the spinal canal. And although this material can be seen on a parasagittal image here, I think that it helps us understand how it might be missed and overlooked if sort of not specifically looking for that. And I guess the same applies to transverse sections, although we might be able to see them on those depending on how large, how obvious, how craniocaudally extensive, and also depending on the slice thickness chosen, they might go unnoticed in these cases. And that's why we consider that the use of stir sequences and the administration of contrast was helpful, particularly in more discrete herniations, and that therefore we suggest the use of these images. So dorsal stir, a T1 post-contrast at the level of the intervertebral disc and foramen, or ideally, or alternatively, I guess, a three-dimensional reconstruction technique in cases where the signs are compatible with a foraminal or far lateral disc herniation. Additionally, obviously, we found that radiography was a good screening test to help us discern between an orthopedic or neurological cause of lameness or pain in these cases, and that was particularly in those that present with pain on hip manipulation alone, which obviously could lead us to think initially of an orthopedic cause, when most likely in these cases will be secondary to applying traction on the spinal nerve. The other point to consider was that despite having collected cases from 7 different referral institutions around the world, we could only get 37 cases. Although we could have missed some cases, and that's certainly possible, we think that it's more likely further highlights how uncommon the condition is. Although again, we might have missed some cases. And then obviously finally, given the small sample size, the fact that surgically and medical treatment protocols weren't standardized, and obviously were very variable from clinician to clinician and center to center and case to case. The clinical presentation of surgically and medically treated dogs obviously differed, as I said, and then all surgically treated animals underwent several types of medical management before surgery. We didn't think that it was appropriate to perform statistical comparisons between surgically and conservatively treated animals in this study. Obviously, our study was hampered by several limitations, mostly those that are inherent to its retrospective and observational nature. The other ones are the fact that long-term outcome was in most cases assessed via a standardized questionnaire that was answered by the owners, which we know is a subjective tool. It would have been preferable to use an objective and validated outcome assessment measure. Also, long-term outcome information was only available in 84% of dogs, and this was mostly due to the fact that ethics and the welfare committee guidelines dictated that only owners of animals that were alive at the time of outcome assessment could be contacted. But still, we did lose some patients to follow up, unfortunately. The treatment choice was also clinician dependent, which again is a source of selection bias, and that finally all included cases were seen at referral centers, which we know can have skewed the population towards a more severe presentation that didn't respond to initial medical management. And so in terms of, in conclusion, most dogs in our study, so 93%, had a good to excellent outcome following either medical or surgical treatment. And considering that most cases presented with at least one neurological exam abnormality besides lameness and back or hip pain, I think our study reinforces the importance of a neurological exam and cross-sectional advanced imaging in dogs that present with pelvic limb lameness or lumbar or hip pain without obviously an obvious orthopedic cause. And as for the future, we believe we need further studies with higher number of cases and prospective and standardized treatment and outcome assessment methodologies for us to really be able to compare results of conservative and surgically managed surgical and conservative management of foraminal and lateral disc herniations, and hopefully understand which patients actually do require surgery. And that's it for me. I'd just like to thank the neurology team at the University of Glasgow, in particular Rodrigo and Roberto, for the project. From the University of Bern, Julien, Alexandre and Frank. Also Stephen at the RVC, Joseph at Anderson Moores, and Christian at the University of Barcelona. And then Natasha at NC State, and also the University of Wisconsin-Madison for contributing to the paper. Obviously, a special thanks to Rodrigo for the project idea and for being such a supportive tutor. And finally, thank you very much, everyone, for listening to me, and to Laurent and Simon for the invite. And obviously, it is an honor to be on this side of things. So thank you very much for the invite. Really grateful for that.
Thank you so much, Sarah. I need to remind everyone that Sarah is just finishing a first-year residency. Before the webinar, Simon and I were just chatting together, and I suddenly remember that at the end of my first year residency, I was still trying to make sense of what was thrown at me on clinic. And certainly I didn't have a study already published like Sarah did, but rather was trying to think what the hell I could, consider studying as my residency project. So hats off to Sarah for already having a paper, and more importantly for being brave enough to actually put herself forward and present it to us in an extremely professional way. So, really well done. We're going to take a few questions while people put their question forward. I would just say that this far lateral and foraminal disc extrusion are certainly not very common, but I also believe they are probably underdiagnosed. And we see an awful lot of MRI that we report, Simon and I, and very often the study is probably not complete in a way that no dorsal view are done, no dorsal stare, and often you find this far lateral because of the telltale sign, which are you see some changes on the dorsal stare that then prompt you to look a bit more carefully at the parasagittal, and you may be lucky that someone has done a transverse, but even so, very often you only see it because there is loss of the fat signal, so not easy to diagnose. But I also believe there are often miss on a lot of the MRI study. So let's take a few questions. The first one: did you have to exclude many dogs with due to the presence of material within the canal? So I presume some of them had foraminal and far lateral, but you excluded any of them that also had material within the canal as well.
Yeah, certainly we did have to exclude quite a few of them, just so that we wouldn't include any cases in which spinal cord compression rather than nerve root compression was seen. So certainly that was the case for a few of them. Certainly, and obviously we know these breeds are predisposed to it, and so in some of them they had recurrences in which we had to exclude them just simply for that reason.
Let's see another question, and feel free if you have any question to put them forward as well. Did all the MRI included post-contrast sequences?
No, unfortunately not. We only did administered contrast, I think, in 19 out of 38 cases, and so certainly that highlights that in some cases that wasn't performed, and maybe might have been helpful, but in a lot of those, sort of instead of a contrast post-contrast sequence, a 3D reconstruction was made, or that dorsal stir sequence that I've mentioned, and so we ended up doing those instead.
Probably what would be interesting for the people listening while we wait for other question. If you got a case like that and you say, well, let's try first medical management, and if it doesn't respond, let's go for surgery. How long, in average, do you expect the dog that are meant to improve, to take before to say that's enough, let's go for surgery?
Yeah, I think that's a very interesting question. We actually didn't look specifically into that in our study. I guess giving it a time frame is tricky, because again there is limited literature on the topic, and this is sort of the first case series that collates a large amount of numbers, relatively large. It's not even that large, I guess. I think certainly if they don't respond to pain relief within, I guess it depends on the degree of pain that is seen, and obviously whether that's felt tolerable by the owners. I think this is a big factor. We often will place them on sort of a non-steroidal as well as gabapentin and paracetamol. In some cases, we'll hospitalize them and keep them on opioids. So I think it would be hard for me to say, definitely if this happens, we definitely need to do surgery, or if this doesn't happen, we don't have to. But in typically we will, if they don't respond to an opioid, then we will typically elect to go for surgery in disc herniations in general.
Before we take a question, what always strike me on the MRI of this case is how well demarcated the extrusion is on the far lateral. And it's something I've never really understood, is that there is space really to expand. So when he extrude in the vertebral canal, sometimes it's very well demarcated, but also it tends to expand cranially and caudally to the side. but they're always so well defined, and it's really striking, when you see them on the MRI. Let's take a couple more questions. Did you find in all cases hyperintensity at the level of the lesion on stair sequences?
Not in all cases. I think all but. Let me just double check our numbers. Actually, now so not all cases. 57% of cases. So not all of them. So I guess it's not 100%. So I wouldn't trust it.
So some of them have stair hyperintensity and some of them didn't have, I presume.
Exactly. Yeah.
So the fact that you don't have hyperintensity on stair doesn't rule out the presence of a far lateral. And I presume you didn't see any correlation with how long this has been going on and the presence of stair hyperintensity or the absence of it.
We didn't look into that actually, but it would have been interesting, as well as, for example, looking at whether when they had calcified disc material in the X-rays, whether that was for the more chronic or acute cases. So obviously that would have been interesting to look at actually. But it was sort of quite limited number of cases, so it is hard to do statistics on that, I think.
Let's take a last question for you, Sarah. How many cases, that's an easy question, had low field versus high field?
That's a good question. I think only 2 cases had low field MRI and all others had high field. So that might be a factor as well.
Yeah.
Yes, certainly.
And I presume, the slice thickness could sometimes, play a role as well, and it could be easy to miss, depending on the type of protocol you use. Sarah, thank you so much for doing a great job. As I say, very, hats off to you to actually come to present the result of your study. We would like to invite, again, anyone like Sarah, who has done, a research project that is about to be published or that you've published. This platform is primarily for you, not for all geezer like Simon and I. We want to give you this opportunity to present your work and, to make yourself known and also to practice, to a wider audience. So if you have anything in the pipeline or about to be published, contact us on the Facebook page. And I leave the last word to Simon.
Yeah, thanks very much. And just to reiterate what Laurent said, thanks so much, Sarah. That was a really well put together presentation and help people understand why you did it and what you were looking for, what you got out of it. It was really good, and again, admirable at your stage to be doing this. So thanks very much for that, and thanks to everyone who's tuned in. Really appreciate your time, and hope to see you at the next Journal Club, which is going to be in the first week of August. And as Laurent said, please volunteer if you have a study coming out or has just been published. We'll hope to see you at that time. And thanks again to Hallmark for sponsoring these sessions. Thank you.
Have a good evening. Bye-bye.
Bye-bye.
Thank you very much.